All right, and welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and we've got two great guests today. We've got Dr. Wendaline VanBuren. She's an associate professor of radiology in the Mayo Clinic Department of Radiology. She's the chair of the GYN imaging section in the Division of Abdominal Radiology and the founder of the International Endometriosis Imaging Congress. And then Dr. VanBuren, we typically use first names on the show. Is that okay with you?
Absolutely. Please call me Wendy.
Wendy, all right.
Yeah.
And an old friend of mine, Dr. Tatnai Burnett, minimally invasive GYN surgeon, also at Mayo. He's an assistant professor and minimally invasive GYN surgeon in the Mayo Clinic departments of OBGYN, surgery, and pediatrics. And they're the co-directors of the Mayo Clinic Center for Complex Endometriosis. Did I get all that right?
Good to go.
Sounds perfect.
Wonderful. Well, welcome to the show, guys. We're glad to have you.
Thank you.
So glad to be here. Thank you for the invite.
Before we get too deep into the weeds, Wendy, tell me how did you get interested in endometriosis? I'm guessing there's not an endometriosis imaging fellowship at WashU. What was your introduction into endometriosis imaging?
Yeah. I mean, like all great things in life, sometimes things just happen to you. You don't plan them, right? So I was just in the reading room one day on an MRI rotation, and I happened to see a case of bowel endometriosis and was absolutely fascinated by it because I thought I was the only one on the planet that had never seen a case of this before. You know, like you feel like you're training, you've come from a different country. Wow, this is amazing. I've never seen this on MRI before. I must be the only one who doesn't know. And so, I kind of became very interested at that stage. And we had the goal of making a grand rounds talk as fellows at the end of the year. So I decided what I was going to do was look up all the cases at WashU. So I did a 10-year RadPath search in their database to try to find all the cases that had gone to surgery and had pathology and then find their imaging correlates. So I was putting it together for the purposes of this talk. And, one day a week, started off as a little bit of dedication that then became devotion. And then, fast forward 10 years later, and I'm still here doing exactly the same thing, finding cases that I find interesting and putting together patterns, discussing them with, clinicians and surgeons and learning every day from it because it is super challenging. It's very interesting and there's nothing straightforward about it.
It sounds like you were curious about it. I mean,
Yes.
Genuine interest. I think curiosity is the most powerful force on the universe. People talk about passion. Passion burns out, I think, but I get curious about something like just don't even talk to me. And so
Right. Yeah.
I'm an administrator now. I'm a CMO, which is an interesting new role, but finding people who are curious and giving them an opportunity to just go do what they do, like just get out of their way, right? I think so. Finding a place where you get to do that is great, where you have someone people who are interested and supportive to allow you to chase that curiosity. That's good leadership to me. That's someone who understands like, okay, this is, I don't have to tell them to do interesting work. They're going to do it. During that time, so 10-year period, how many cases of endometriosis did you find? Like, was it thousands? Was it hundreds? What were you?
So that's interesting. Like Tatnai and I were just talking about that prior to the podcast. There was no, recommendations for preoperative imaging or evaluation. These were cases that were seen haphazardly on imaging, right? So the volume wasn't actually that high. It was probably in the order of a couple hundred cases, but it was enough to have, pattern recognition type of learning, which is what, our training in radiology, as many other disciplines in surgery too. You don't learn just, the one lesion, how it presents, you learn how that pattern of disease presents itself. So, shockingly to me at the time, I thought, wow, this is just like all other diseases. It has pattern recognition to it. The bowel lesions tend to look similar. The bladder invasive lesions do. This glandular aspect to it, some of the variability. So it was a very interesting process to go through, but the volume of cases wasn't terribly high at the time. And there wasn't that prospective element that, that came when we started in practice together. So all of that was retrospective. It was still very interesting and quite comprehensive because the one great thing about that is that you do get to see, especially at a large academic institution, a great breadth of pathology.
That's interesting. And so Tatnai, I know we both trained part of our careers at Michigan, but you went on to fellowship in Illinois. Was MRI imaging. Talk about how you learned about MRI or what imaging modalities you used in training and sort of what your process was and how that's evolved since starting your practice as a member of a faculty.
Yeah, so I actually, while my fellowship program was excellent in a lot of ways, it actually didn't have a significant endometriosis component, believe it or not.
It's interesting. I mean, Michigan didn't really have there was tons of fibroids. And like a lot of the people that we've seen and trained, like, oh, we took out huge uteruses and fibroids, but like, it's interesting how different each fellowship can be. And I felt like most of the endometriosis learning I did was as an attending, and we had Peter Mavilla joined us for a little bit, and he was someone who did tons of endometriosis surgery and fellowship, and really, honestly, learned a lot from him as well.
Yeah, I definitely felt that residency at Michigan prepared me from a pelvic pain perspective. Learning a multidisciplinary approach to pelvic pain, multifactorial nature, central sensitization, pelvic floor, all of those things, medical management of dysmenorrhea, adenomyosis, endometriosis. I felt inadequately prepared for surgical management of endometriosis with both my residency and my fellowship. And I didn't realize the extent of the gap until I did some time as a fellow with a gentleman named, probably most people are familiar with, Ken Cernervo in Atlanta. So he's one of the self-proclaimed very good endometriosis specialists. He's one of those top tier surgeons. You watch him operate and he's slick. He sees planes. He does things well. But I spent some time with him towards the end of my fellowship because I heard from another fellow at another institution that they learned really good things spending time with him. So I went there. I watched him operate. And more than that, I watched the things that he was choosing to remove. So to me, in the endometriosis world, there's the superficial disease, and that has its own operative skills. Primarily recognizing subtle lesions really is the true skill for the superficial endometriosis surgeon. I saw Ken Cernervo choosing to remove things that I had been told over and over again in the past were, oh, that's nothing, that's not endometriosis. And then I got to correlate that with the pathology after the surgery and see what was coming back endometriosis from his surgeries. And honestly, it blew my mind. It just turned everything on its head about what I had been told was and was not. And I was like, wow, like I was not doing it right. And then the second piece, the other piece to endometriosis surgery is dealing with complex disease where there's significant fibrosis, adhesions. And that is very challenging surgery. It's a totally different skill set. It almost pulls you back towards a little bit of gynecologic oncology surgery, except we operate in slightly different planes. So combining those two things was what I envision as being a complete endometriosis surgeon. So I had the pelvic pain training from Michigan. I then got this excellent glimpse into what endometriosis surgery could be, what recognizing superficial endometriosis was actually entailed. And then I took those skills and when I arrived at Mayo Clinic, I billed myself as a chronic pain endometriosis specialist and been riding that boat the whole way since.
It is interesting, not just the variability. I mean, I think this is something someone told me years ago, but if people say there's more than one way to do something, it's because we don't know the right way yet, right? Correct. And I think that
you don't know what you don't know.
I've talked about this on the show a few times, but the emperor of all maladies and how we thought about cancer as a surgical disease and sort of, all the advances in the last 100 years, of all the advances, like none of them have been surgical, right? It's all understanding where the disease comes from, all the way from chemotherapy down to targeted therapies. We're decades, if not a century behind in endometriosis. We don't even know what it is or where it comes from. And there aren't many diseases in this healthcare system that we just tell patients, sorry, I have no idea what this is or where it comes from. Could it be infectious? Maybe. Could it be embryologic? Maybe. Retrograde menstruation? I don't buy it, but you haven't proved to me that it's not. We all have theories, but there aren't a lot of diseases in healthcare these days where it's just like, could be I don't know. Like we've had a number of guests over the last couple of years and a lot of different theories and ideas. The reality is I don't know that anyone can tell you right now where it comes from. And so the idea that excising it and what the value of it is even really, right? I mean, because then the downstream effect of the fibrosis and leftover scar tissue after this disease is removed. And so I'm not saying this is another podcast entirely, but it's a challenge, right? I think as we are all trying to figure this out. There's a lot of folks working on what that is. But one of the most important things to back up to sort of why you guys are here is that we have patients that come see us that have pain. There are some things that help us steer one way more or the other, or they may have endo, but like they have clear musculoskeletal pain. Let's try medical management and PT first and sort of see how it goes, and we can treat them as if they had it. But at some point, we have to decide whether or not surgery is something we're considering. I guess let me go back. Like currently how I do it is, we think surgery can help. MRI is a way for us to sort of like know what we're getting into. But just being able to tell somebody they have endometriosis, or we think they have it, is a very powerful thing to tell somebody, right? So at this point, we start with ultrasound. Sounds like what you guys are doing is a lot of MRI. I mean, I guess Tatnai, start off telling me, like, what's your imaging workup when you see somebody for, not someone who's sent to you for endo, but like chronic pelvic pain? Like, what's your sort of like workup, history exam, plus minus imaging? Like, briefly talk us through that.
So just to hop onto something that you mentioned, how validating a patient and their disease and how imaging can be helpful with that, that you were kind of alluding to. The point I want to make about that is it's a two-edged sword, right? So I have way too many patients who come to me and they say, well, my doctor did an ultrasound, it was normal, so they said I don't have endometriosis. Or my doctor did an MRI, it was normal, so they said I don't have endometriosis. So the first thing I would say is, let's just put out there on the table, we're not using imaging to rule out the presence of disease.
We don't tell patients you don't have endo. We tell them we don't see signs consistent with endometriosis. But that's right. We don't rule it out. That's absolutely right. Very important point.
And at this point, we haven't gotten to the point yet, although maybe we'll get there in the future. We haven't gotten to the point yet where we can really identify superficial disease prior to surgery, not with any degree of reliability in any case. So in our practice, we really use imaging as a guide for how to do surgery, how to approach surgery, how to counsel patients preoperatively. Now, I would tend to separate patients kind of into two groups, Mark. There's the patients who have not had a prior surgery, and then there's the patients who are coming and they've had 2, 3, 4, 5, 6. Okay, I've had one patient with 21 surgeries, right? And they're a little different in how I approach this question. And then I'll divide those patients again into those who we find deep endometriosis on imaging and those who we do not. So when we take the patient who's coming in with symptoms, our typical approach used to be, at least for the patient who's not traveling, is we sort patients into who needs advanced imaging by some criteria. Now, our practice, because it's international, because patients travel a lot, we often just order that MRI up front. But in most default, patients who don't have a nodule on imaging, don't have bowel symptoms that are suggestive, don't have bladder symptoms that are suggestive. They just have dysmenorrhea. Their bowel function doesn't change with their period. Nothing changes. They just have that pain. Then routine ultrasound to rule out endometriomas or anything else major. And then we can go ahead and operate if it's the right move. Now, there is not consensus right now on if you have negative imaging, no signs of deep endometriosis, what is the right thing to do? And I've seen opinion pieces saying we shouldn't be operating on superficial endo. It's a medical disease. It's a central sensitization disease. I still feel at this point, again, because data is not great. Okay, so I'm going to go with feelings because that's what I have left. I still feel at this point that every patient deserves an excellent endometriosis surgery, at least one, primarily because yes, there are multiple pain factors in multiple patients. Yes, pain can be central, but addressing pain generators adequately, even in the patient with central pain, I think has value, right? So
are you operating on patients that have primary dysmenorrhea that are treated with medical management? They're asymptomatic. You're still...
No. So based on symptoms.
So say that they had periods that were painful in the past. You put them on birth control pills. They're doing great.
Then that patient, typically I wouldn't have an indication to operate at that point, right? Okay. So it's based on symptoms. Symptoms drives the surgery. But I do have patients who come to me and say, I have painful periods and I don't want to do hormones. I don't like hormones.
Right,
I don't like the idea of hormones. Then I'm not going to say, you need to be on a hormone first before I'll operate on you. I do
Very
agree.
Important point.
Yeah. Patient autonomy, for sure, it needs to be respected. But I do agree that it increases the pretest probability if someone fails hormones. It really just raises the likelihood I'm going to find it at surgery. Definitely agree with that. But, right now we do not have great data that says operating early on someone whose symptoms are controlled on hormones makes a difference to their long-term prognosis with endometriosis. Is it possible it does? It's also possible it doesn't. Since surgery is a tool with risk, I have a hard time suggesting and applying it when I don't know that there really is a significant future benefit in those patients, right?
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.